Today we are going to read about the pre-invasive lesions of the cervix, and this is the first lecture that we are going to discuss. So, first of all, the cervix is made up of two epitheliums. The epithelium that lines the ectocervix and the vagina is known as stratified squamous epithelium. Why it is called as stratified? Because it is multi-layered. And why it is called as squamous? Because multiple layers of flat cells is present, and these cells increases in size as we go from down to upwards. So the stratified squamous epithelium lines the ectocervix and the vagina, and the projection of the stroma is known as the papilla. So this is the papilla. This side is known as the stromal papillae. Now, this stratified squamous epithelium is made up of four layers of cells. First one includes the basal cell layer, then the parabasal layer, then the intermediate cell layer, and the superficial cell layer. You can see that if we are going to move from down to up, then the cell size is getting increased, it is becoming more flat, and the nuclei is getting reduced in size. So as we move from basal to superficial, there is increase in size and reduction in the nuclear size, and the maturation of the this layer is dependent on estrogen. So in menopause and perimenopausal group, parabasal and basal cells predominates, while in reproductive aged females, intermediate cell layer or the superficial cells predominates. Now, another epithelium known as the columnar epithelium, which consists of elongated cell, and their nuclei is present at the base. This is a columnar epithelium which lines the endocervical canal as well as the uterine cavity, and it is a single cell layer with darkly stained nuclei, and it is reddish in appearance. So this is bluish in appearance and this is reddish in appearance. There is one terminology known as the endocervical crypt. So these crypts or the multiple longitudinal fold-like structure known as endocervical crypts is present in the columnar epithelium, and it is around 5 to 6 mm in size. So while we try to destroy the pre-invasive lesions of the cervix, then we try to destroy at least 7 millimeters in case of malignancy. Now it has grape like appearance, and if there is localized overgrowth of this structure, then it can lead to cervical polyp formation. Now, coming to the squamocolumnar junction, the cervix is comprised of two junctions. First one is the original squamocolumnar junction and the new squamocolumnar junction. So, the original squamocolumnar junction is seen at the level of the external os, where, so if this is the external os, this is the endocervix and this is the ectocervix. So which gets everted at the time of puberty and exposes the columnar epithelium. So this area where the squamous epithelium changes into columnar epithelium is known as the squamocolumnar junction, and this squamous epithelium sometimes grow over the columnar epithelium, which makes a different color of the zone, and this is due to squamous metaplasia. So the region between the this new squamocolumnar junction and the region between this original and new squamocolumnar junction makes the transformation zone. Now there are certain images. This is the fetal image. This is the original squamocolumnar junction, and it gets everted due to the presence of maternal hormones. So in the presence of hormones, this gets everted, and if the hormones are lesser, then this will get inside. So this is prepubertal, where there is no maternal hormone, so it is getting inwards and it is getting outwards. Same as for post-adolescent female, it is getting outwards due to the presence of hormones, and the transformation zone is this is the new squamocolumnar junction, and this is the old squamocolumnar junction, and the region between the two is known as the transformation zone. While in postmenopausal female, where there is no maternal hormones, the transformation zone shrinks, or the new squamocolumnar junction goes inside. In postmenopausal female, the transformation zone moves inside the endocervical canal. Epithelial components of transformation zone. The transformation zone consists of columnar epithelium folded into crypts and the papillae. This columnar epithelium has reserve cells which can lead to squamous cell metaplasia or the growth. So what is squamous metaplasia? Squamous metaplasia is when the squamous cells grow over the columnar epithelium at the place of the crypts gland secretion. So if this is the squamous epithelium and this is the columnar epithelium, this squamous epithelium grows over the columnar epithelium, and if crypts are present, then they will try to secrete the secretion, and this secretion gets blocked, and there is elevation of these structures, and these structures are known as a Nabothian cyst. So the gland secretions becomes stagnant from the crypts due to squamous metaplasia, which later becomes cyst known as the Nabothian cyst. Outer limit of the Nabothian cyst forms the boundary of the original squamocolumnar junction. Now, what does HPV do on the transformation zone? So this columnar epithelium has the reserve cells which can transform into the immature squamous metaplasia, and if there is transient or no infection with oncogenic HPV, then maturity occurs in this squamous epithelium, and if HPV is oncogenic in nature and transforming infection is occurring, then it can lead to dysplastic epithelium. In some cases, the patients may erode the virus. In latent infection, the virus clings and multiplies in the patient's body, leading to productive infection. But on follow, they do not develop cancer, that is, low-grade lesions are seen. Transforming infection, viruses becomes an episome. This viral episome gets integrated into the host DNA, and uncontrolled multiplication leads to the development of cancer. Now, different HPV infection stages. First of all, the HPV gain the access to the microinvasion or the abraded area, and it will infect the basal cells. Usually in 80% of the individual, this infection gets cleared on itself, and if it does not get cleared, then more cells are affected and leads to the formation of cervical intraepithelial neoplasias. So when the basement membranes get affected and there is breach, then it is carcinoma, and if the breach crosses the basement membrane, then invasive cancer occurs. So in this, with exposure of HPV, initial exposure of HPV, this is the normal epithelium and this is the exposure of the viral particles. Then there is around 90% clearance of infection in the stages CIN1 and almost 70% regression in CIN2, where there is 1/3 of the basal epithelium is infected. Here more than two-third is infected, and if more than two-third is infected, then it is CIN3, but the basal membrane is intact. While when the basal membrane gets breached and the cancer cells spread into the nearby spaces, then this is cancer or basement membrane is breached. Now, so for cervical screening. So how do we screen for the cervical cancer? So there are certain general screening methods. We have divided it into cytological methods, HPV based methods, and the visual inspection methods. First one is the cytological method, in which we can either do conventional pap smear or the liquid based cytology, and the third is automated screening. HPV testing and visual inspection can also be done. Coming to pap smear was first invented by George Nicholas Papanicolaou in 1927 at the Cornell Medical College, New York, while studying the morphology of exfoliated cell. So how will you take the conventional pap smear? It is done by using an IRS spatula from the ectocervix. So through this IRS spatula, we take the ectocervical sample, and the endocervical brush is put inside the cervix and then rotated clockwise 5 times to get the endocervical sample. Then these samples are smeared onto the slide, and we try to fix it through 90% ethyl alcohol and diethyl ether solution. The sensitivity of pap smear is around 55 to 60%, while the specificity is slightly higher, that is 80 to 95%. Inadequate sampling occurs in 5 to 10% of the patient. So if the test is demonstrating as inadequate sampling, then we can increase the sensitivity of the test by doing a repeat test. So this is the instruments that we use for pap smear. First one is the Cusco's bivalve speculum, this through which we can visualize the cervix, and this is IRS spatula. These are the endocervical brushes, these are the slides, and this is the Coplin jar where we cap the fixative solution and we dip the slide into this jar. So this is the method of cervical pap smear sampling. Up to 20% of the harvested cells are transferred to the slide. So what is liquid based cytology? Sample dispersed in the liquid suspension. So we collect the sample through this way only, and then we have only this cytobroom is present in the liquid based cytology instrument, and the sample dispersed into the liquid suspension, centrifugation passed to a filter which prepares a monolayer preparation. The cells that are dispersed in the liquid based cytology jar can be sent for the HPV DNA testing, and it is preserving the cellular morphology. There is absence of air drying, and cell crowding and obscuring cells are not present. Two LBC technologies can be seen, that is, first is thin prep or the sure path, and this is thin prep is methanol based fixative, while sure path is ethanol based fixative. You can remember, like, thin means less means less carbon, so less carbon means methanol. So methanol based fixative is thin prep, and ethanol based fixative is used in sure path solution. The liquid based cervical cytology is neither more sensitive nor more specific for detection of high grade cervical intraepithelial neoplasia compared to the conventional pap smear. So the sensitivity and specificity of both of these is same. The main advantage is that the adequacy is better and the glandular components are better identified. We can do HPV DNA testing, and there is monolayer preparation. So well preserved cellular morphology is there, and there is absence of air drying, cell crowding, and the obscuring cells. Now, what is automated screening? In this, we use a video microscope image interpretation software and try to analyze the images and classify abnormal cervical cells. Screen slides give a score and adequacy statement. If the score is more than 30, then we re-screen it by cytotechnologist, and AutoPap 300 PapNet can be used for automated screening methods. Now, for staining of the slides, either for pap smear or liquid based cytology, these slides can be stained through 5 dyes. First one is the hematoxylin dye. This hematoxylin dye stains the nuclei blue and black. Then OG6 counter stain. OG6 stains the keratinizing cells pink or orange. Second EA contains 3 dyes, that is eosin Y, light SF, light green SF, and Bismarck brown Y. So this eosin Y stains superficial epithelial squamous cell, nucleoli, cilia, red blood cells, red or pink. Light green SF, yellowish, and cytoplasm blue and green. Bismarck brown Y. This is also present in this staining. Coming to the Bethesda system of classification, this is the reporting system used for cervical cancer, and the National Institute of Health in Bethesda given the first Bethesda workshop where 3 dozen laboratory clinicians and research scientists were there. Then it is again revised in 1991, 2001 and 2014. The recent Bethesda system that we use is of 2014 Bethesda. The aims of the Bethesda system is to provide effective communication from lab to the clinical provider, facilitate cytohistologic correlation and consistency. Cytologic means pap smear and histologic means corpuscopy directed biopsy. Facilitate research into the epidemiology, biology, pathology of the cervical disease updated according to the recent advances, and provide reproducible, reliable data for national and international statistical analysis comparisons. So what is the 2014 Bethesda system? First point in 2014 Bethesda system is we will try to classify the specimen. So whether the specimen is taken through pap smear or the liquid based cytology versus other like automated screening. Then we check for the specimen adequacy. We will check for the whether the specimen is satisfactory for evaluation, that is endocervical or transformation zone component is there or not, or any other quality indicators like partially obscuring blood or inflammation is also present or not. So it can either be satisfactory for evaluation and unsatisfactory for evaluation. So what is the reason for unsatisfactory specimen? We have to specify the reasons, like specimen rejected, not processed. So the general categorization is there whether the report is negative for intraepithelial lesion of malignancy, that is normal pap smear report, or we have to interpret if any abnormality is there like endometrial cells in more than 45 years of age, or if epithelial cell abnormality is there, then we have to classify it whether squamous or glandular. Non-neoplastic changes like non-neoplastic cellular variation, metaplasia, keratosis, tubal metaplasia, atrophy, pregnancy related changes are mentioned. Reactive cellular changes like inflammation, lymphocytic cervicitis radiation, IUCD, glandular cell status post hysterectomy, organisms like trichomoniasis, candida, bacterial vaginosis, actinomyces, HSV and CMV, etc. Now we have to report about the pre-malignant squamous lesions. If squamous cells are there, then whether squamous cells are atypical squamous cells, could be ascus or the ASCH, LSIL, HSIL and the squamous cell carcinoma. Ascus and LSIL are low grade lesions, while rest are the high grade lesions. Now glandular cells, atypical glandular cells, endometrial cells are the glandular cells, and atypical endocervical cells favors neoplastic, or glandular cells favors neoplastic endocervical carcinoma in situ. Now there is adenocarcinoma, endocervical, endometrial, extrauterine, not otherwise specified. Now we have to tell about the specimen adequacy. So till now we have discussed about specimen type, satisfactory specimen, and classification of a specimen, and then specimen adequacy. Minimal squamous cellularity requirement for a specimen to classify as satisfactory is if in a conventional smear, that is pap smear, 8,000 to 12,000 well visualized squamous cells are present, and if on liquid based cytology preparation, at least 5,000 squamous cells are present. Most common cause of inadequacy is the low cellularity. Women who have received radiation, chemo, trachelectomy for invasive cancer, atrophic reparative changes, cervix stenosed or altered anatomy, and such specimens even less than 5,000 should be considered adequate. Less than 2,000 in these patients is inadequate. So first image is showing no cell, that is unsatisfactory scan cellularity. Then there is clump of this, so abundant endocervical cells but squamous component inadequate, and here also low cellularity but satisfactory specimen from a woman with history of pelvic irradiation. Now we have to mention whether the specimen is partially obscured or completely obscured or well visualized. So partially obscured when the 50 to 75% of the epithelial cells cannot be visualized, and if more than 75% of epithelial cells are obscured, then this is unsatisfactory. It could be due to WBCs or inflammation. So if 50 to 75% of the epithelial cells are covered, that is partially obscured, then we have to mention the cause of obscuring the specimen. It could be blood or the inflammation. Now in this image you can see that this is completely covered by the blood, and there are some cells which are visualized. So this specimen is partially obscured due to the blood, and then this is reprocessed with glacial acetic acid, which has dissolved the blood component, and now you can easily see the normal cells in this specimen. Now what about endocervical and transformation zone component? The adequate specimen, only squamous cellularity is necessary. Presence of transformation zone component should be reported, and it is useful for quality assure measure for both conventional and liquid based preparation. And adequate transformation zone sample requires at least, so we have to look for at least 8,000 to 12,000 cells per smear in a pap smear, while at least 5,000 cells in a liquid based cytology. So those were the squamous cells. Now for endocervical cells, at least 10 well preserved endocervical or squamous metaplastic cell ganglion clusters are needed for adequate specimen satisfaction. Now what is the management related to adequacy? So if there is unsatisfactory cytology, then we have to repeat the cytology, not immediately but after 2 to 4 months, at least 15 to 30 days, and the infection or the inflammation should be treated. And if two unsatisfactory cytology tests are there, then we have to go to the colposcopy but not the pap smear. HPV 16 and 18 positive by genotyping, or if she is age 30 and greater, then high risk HPV is positive. So this is the management of unsatisfactory cytology. So if HPV status is unknown, then we have to repeat the cytology after 2 to 4 months. If HPV is negative in a female more than 30 years of age, then we have to repeat it again. Or if HPV is positive in a female more than 30 years, then we again have to repeat either cytology or the colposcopy. If cytology is again unsatisfactory in this female, then we have to go for colposcopy, as we have discussed. And so this is 2 to 4 months, not 2 to 4 day, 2 to 4 ठीक है, the 2 months, yeah, either 60 days or 120 days. So if it is again negative, then routine screening to be done, or co-testing at 1 year. And if repeat cytology is abnormal, then we have to manage it according to ASCCP guidelines. That's all.